From the JAMA Network, this is JAMA's Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to JAMA Surgery Author Interviews. I am your host, Dr. Jamie Coleman. Today, we will be discussing another article that is perfect in timing because it is October, which is Breast Cancer Awareness Month. We are here with two of the authors of the American Society of Breast Surgeons and Society of Breast Imaging 2025 Guidelines for the Management of Benign Breast Fibroepithelial Lesions. The authors joining me today are Dr. Katharine and Dr. Lorraine Tafra from North Shore Endeavor Health and Johns Hopkins, respectively. Thank you both for joining us.
Thank you for having us.
Great we could be here.
Well, to start, can you just give us a little bit of background about why these guidelines were written and really so needed?
A group of us got together and formed a steering group to oversee development of these guidelines. And there are some guidelines out there for management of benign breast disease, but they're a little bit fragmented and not comprehensive. And we thought it would be a good idea to come up with evidence-based, consensus-based, and most importantly, expert opinion-based guidelines for management of benign breast disease. So this is the first pathway, the management of benign fibroepithelial lesions, and we have three other pathways that we are currently working on.
And so can you talk to us a little bit more about the steering committee and how these guidelines were then created?
So we convened a steering group and we oversaw development of the guidelines along with leaders in the Society of Breast Imaging. And we developed consensus panels and expert panels that helped us formulate and write these guidelines.
And to put a little bit of this into context, I know it's estimated for over 300,000 women to be diagnosed with breast cancer in 2025 alone, but even more are diagnosed with benign breast disease. And so how does this play into how often or how frequently these guidelines are going to be used? In other words, how many women are affected by benign breast disease?
Well, I might let Dr. Tafra estimate, but it's hard to put an estimate on that. I would say that most breast surgeons would agree that they're seeing far more benign breast disease in their clinics than they are seeing breast cancer cases.
Yeah, I would agree with that, Doctor. Yeah, if you look at the number of patients that actually get a core biopsy, a needle biopsy, not an open surgical biopsy, it's over 1 million a year. So it's a huge volume of women that are faced with, and of course they're facing, is it benign or is it malignant? So a lot of anxiety associated with that. Fortunately, they're usually benign.
And I think that was part of it when you're reading these guidelines and for everyone who's going to be reading them. And you really put this really well in context where you're saying there's so many surgeons now who are seeing this benign disease. Having a consensus set of guidelines for treatment is just incredibly important. And so let's cut to the chase a little bit and let's talk about the guidelines themselves.
I'm going to interject just to say Dr. Yao is being incredibly humble in her explanation of how these guidelines came to be. It was Dr. Yao who appreciated that we don't have a good set of guidelines, and to actually get the support from the ASBRS to put forward this huge endeavor is challenging. You have to go through a lot of committees. So this is a huge endeavor, truly, from someone who had a vision of what would benefit the surgeons to give them the best chance at taking care of breast patients. So my hat goes off to her.
I love it. And I think it also speaks to, again, kind of how these guidelines are made. I mean, at the end of the day, you can look at these guidelines and say, oh, this makes sense or this seems straightforward. But the amount of work that goes into creating a steering committee.
Huge.
And getting a group of surgeons to agree.
Oh my gosh. Right.
On anything. So, I mean, can you imagine? We can't agree on what color the sky is, much less, on anything clinical.
And you would think that it would be much more difficult to do guidelines for cancer patients, for breast cancer patients. But in fact, trying to do guidelines for benign disease, as Dr. Yao can tell you, was even more challenging from the standpoint that we've been managing benign disease for 100 years. So our literature is old because all the attention goes to your cancer patients. So new studies on how to manage fibroadenomas are relatively challenging. And you may want to mention the discussion around our guidelines, our guardrails that we put up for even looking at the literature.
Yes, I would agree. It is a long process. I think from the start to finish with this first pathway has been in over a year and a half. And there have been lots of people involved. But I think we've come out with a very good product. And I think it will be great for our members to have these guidelines as a quick and easy reference for when they're in the clinic and how to manage these lesions.
And I think especially for general surgeons who have a general practice, who may not spend all of their clinical time in breast, I really encourage every general surgeon to download this paper. It's so well done, great tables, great charts to really walk you through. And so to sum up at least part of it, let's talk about the indications for surgical resection or surgical excision.
So the way that we broke up these fibroepithelial lesions, there's a section on fibroadenomas, and then there is a section on benign phylloides tumors. So I will address indications for excision for fibroadenoma. We have moved more towards a de-escalated approach, and we state that we do not recommend routine excision of biopsy-proven fibroadenomas. Fibroadenomas should be removed if a patient prefers to have them removed or they're symptomatic, if they've demonstrated substantial growth. If they are reaching a size of 4 to 6 centimeters, then that would be an indication to remove them. And if they have any associated atypia, that would also be an indication to remove them.
Yeah, I might just throw in there too that it is important, I think, for surgeons to appreciate that a patient can complain about a fibroadenoma and say, oh, this is causing me pain. But you can have pain that's diffuse through the breast just from having a breast that has absolutely nothing to do with your fibroadenoma. So it's important for patients to appreciate we can take out your fibroadenoma. And a lot of women, oh, by the way, just don't like to feel a lump in their breast. But that may not take away their breast discomfort. So that's another conversation to have that surgeons can have with the patient in discussing should this fibroadenoma be removed or not.
Yes, that is a very good point. And I would also mention that complex, cellular, and juvenile fibroadenomas should all be managed as standard fibroadenomas. I feel that I see a lot of fancy pathology reports describing these, and it always made me a little worried. Is a cellular fibroadenoma different than a standard one? But clearly, the literature has not shown that they're any different. They should just be managed the same as all the other fibroadenomas. And Lorraine, do you want to talk about indications to excise the phylloides, benign phylloides tumors?
Yeah. So phylloides is a very interesting tumor, and it's rare. And it can look a little bit more suspicious. It tends to look like a fibroadenoma, feel like a fibroadenoma, but then when you do an ultrasound or a mammogram, it tends to grow a little bit more. Its margins are a little bit more lobulated, a little bit more irregular. So you're already having a hint, maybe this isn't just a straightforward fibroadenoma. And typically in the past, you would resect them, and because there was a chance of getting a recurrence, you would also try to get a little margin. And that's where things have changed a lot. But the challenge with the phylloides tumors is that patient presents with a mass, they get a core biopsy. The core biopsy typically will not come back and say, this is a phylloides tumor. They will say, this is a fibroepithelial lesion suspicious for a phylloides tumor. So you typically do not know going in whether it's a phylloides or not. It could very well just be a fibroadenoma. And that always posed a little bit of a dilemma for us in the past because should we get a margin? Should we not get a margin? But now there have been some good studies, and if we can talk about those that have showed that you really don't need to worry about margins. But they should be excised. And they, unlike fibroadenomas, which frequently can regress, go away, phylloides tumors don't go away. And they typically will grow. So they need to come out.
And so we've been talking about phylloides tumors. Let's talk about margins, because I think that some of that might have changed more recently. Is that correct?
Yes. So in our guidelines, we state that benign phylloides tumors do not need a negative margin. Traditionally, surgeons were recommended to do a 1 centimeter margin around these lesions, but we have looked at the data and it's demonstrated very low recurrence risks for benign phylloides tumors. So if you remove a nodule and it comes back as a benign phylloides tumor and there's a positive margin, there's no need to go back and do a re-excision.
And I would just echo that was also based on, which is unusual for phylloides tumors, based on a very large series, meta-analysis and a series of about 2,000 patients. So that's good data to support that.
Yes.
Thank you both for summing that up for me. Again, I think these guidelines are going to be incredibly useful for so many surgeons and really for so many patients. Well, as a trauma surgeon myself, I'm going to take the opportunity, having the privilege to sit in front of two breast surgeons who are experts in this area and ask you, what are your operative tips or tricks for those of us who aren't operating on the breast primarily when we are operating on benign breast disease?
So I would say, from my personal experience in removing lots of these fibroadenomas, the biggest challenge is actually finding the nodule, which sounds sort of funny. But these patients are all younger. They all have denser breast tissue. And the minute you make an incision and you get into the breast, it sometimes can be hard to differentiate dense breast tissue from the nodule. But it's important to dissect down to the nodule. You don't want to be removing a lot of unnecessary normal tissue because then the cosmetic outcome won't be as good.
Dr. Yao and Dr. Tafra, thank you both so much for joining me today to discuss the management of benign breast disease. Our listeners can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Have a great day, y'all.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.